So we'll be talking about newborn nursing. It's a case study. So newborn nursing is a little bit difficult, but it shouldn't be. It's just like a little bit confusing, some facts you're supposed to know. So this is the case, and then we'll go through it. So which of the following, this is the case patient. So this is what you have. A 25-year-old female presents to the labor and delivery with lower back pain radiating to the pelvic with a gravid uterus, right? This is buzzword. That statement should give you an idea of what exactly I'm talking about. You should know exactly what is going on with this patient. Client reports she likely in the third trimester. That's what she's telling you. Had a large gush of clear liquid from the vagina, and it felt the urge to what? Have a bowel movement or push, right? Client report to no prenatal care and experiment with the alcohol and street drugs during the pregnancy. No prior pregnancy, history of epilepsy and depression on propionic acid and citrulline. That's the history. 25-year-old presented the labor and delivery, and the key symptoms: lower back pain radiating to the pelvic, and has a gravid uterus. That means she's pregnant, right? She never had any, she thinks she didn't try third trimester, never saw anybody, did not have any prenatal care. She felt a gush of clear liquid from the vagina. And then she's having urge to have a bowel movement and push. If you know in labor and delivery, this is easy. You can figure out what is going on with the patient. You know right there, right? She also said she used some alcohol and some street drugs. We don't know during the pregnancy. She take valproic acid for epilepsy and citrulline for depression. At 0, 9, 10, you find out that the fundus for that as the xiphoid, right? It's 9 centimeter dilated and 80% effaced. Sometimes this kind of case, they'll give you a bunch of information, but you have to pay attention to key facts, right? Plus 2 station. This is all OB 101, like 9 centimeter dilated, 80% effaced, plus 2 station. The presentation is vectors, right? Right. And it is in test 10, the paper to blue. This is telling you all the information from the number 1 at 9 o'clock. These are the vitals, right? The client was placed on a the client was placed on the monitor, and the fetal heart rate is like 140. There's 5 contraction in 10 minutes, all OB, right? And each lasting 60 seconds. IV fluid is running at 100 cc per hour. The newborn was delivered at 11:40, right? And then at 11:41, the newborn was completely blue, heart rate less than 100. The kid grimaces, flex with activity, and has a weak cry. At 11:46, client was completely what? Pink in body, heart rate is greater than 100. The grimaces, active movement, and a weak cry. This is your case. Can you figure out what is going on? There's a lady who's 29, never get any prenatal care. All of a sudden is in a labor and delivery. These are signs and symptoms that you have to put it together and figure out what is going on. And I give it to you. Lower back pain radiating to the pelvis. That means she's in labor, right? And then water has broken. And she told you all the risk factors associated with the pregnancy. She's 9 centimeter dilated, 80% is phase, 2% plus 2 station. That means the baby is about to come out. She's completing a stage 1 and getting to stage 2 to try to get a baby out, right? And then the nitrogen paper tanning, everything blue. That means this is true amniotic fluid, right? We have good presentation. And then the contraction were within normal. And then we deliver a baby at 1 minute, right? Kid is blue, heart rate less than 100. The kid grimaces, flexion with activity, and a weak cry. Then at 5 minutes, we have a pink body, heart rate of 100, grimaces, active movement, and a weak cry. I want to show you some of the things you have to know. I put things you need to know and then put it together. So she just had a baby. never had pregnancy. We don't know how many pregnancies. She has just a precipitous labor, and all of a sudden is delivered, right? But this is a newborn. So what are we going to do? So this is the key. They say, which of the following APGAR score should the nurse assign the newborn at 1 minute and 5 minutes? So that's the key. Do you know how this is? You have to know how to calculate the APGAR score, right? The best one, you color if it's pink, right? If it's your R rate is greater than 100, you're getting good numbers. If your activity is good, you have good cry, you're moving everything, you get full numbers, right? 5 information and 10. At 1 minute, the kid is blue. His heart rate is less than 100. He grimaces, has some inflection, and a weak cry. What do you think is the APGAR score for that? Then at 5 minutes, because probably it's abnormal. That's why we're doing 5 minutes. We have a pink baby, heart rate is greater than 100. The kid still grimaces, has active movement though, and a weak cry. Right. So what is the APGAR score for 1 minute and then 5 minutes? A kid that is blue, this guy gets 0. Heart rate less than 100, you get 1 point. Grimaces, you get 1 point. And then there's flexion. It's not moving completely. There's flexion, you get another 1 point. And the weak cry, get 1. So this is 4. Now it's pink completely. So this, you get 2. Heart rate greater than 100, you get 2. He grimaces, though, you get 1. He has active movement, you get 2. And he has weak cry. So the average score for these two, based on the question, is going to be, it's not 6, 7, 8, it's not 5, it's 4. Remember, first, if you get an APGAR score low, you're supposed to repeat it in 5 minutes. Try to get a number greater than 7. If it's less than 7, it has to be repeated every 5 minutes until you get something greater than 7. So this is what we're going to have: 5, 4, and 8. So this is just want to show you some of the things you're supposed to know. Now, the nurse understand that the newborn most likely as what? Why? So that give you a case now. Now, this is what they have. The nurse observes a sac-like protrusion containing fluid and nerves with no overlying skin at the lower back. The muscle strength is 2 out of 5 of the lower extremities. This is in the formation. After we calculate the APGAR score at 11:47, this is what the nurse saw. What do you think is the kid experiencing? A sac-like protrusion containing fluid, nerves with no overlying skin at the lower back. The muscle strength is 2 out of 5 on the lower extremities. What do you think is the kid is experiencing? So those are your options, right? I give you spinal bifida oculta, meningocele, myelomeningocele, and myelocases. You have to know the difference between them based on the description I provided to you. So spinal bifida occulta is just the spinal bifida with the tufts of air. So you just the air over here like that. The meningocele is just a sac-like. So you have a protrusion here, but there's no neuronal element, no nerve element in it. If you have neuronal element, that means you have some of the nerves come into it, it becomes myelomeningocele. If the spinal cord is involved, that's when you have myelocases. So this kid is experiencing myelomeningocele. So you got to know the difference between them. Okay, you got to know the difference. The newborn is diagnosed with myelomeningocele. Which neonatal intervention will have prevented this finding? Then you go back to your test-taking strategy. You know, it does not matter if it's spinal bifida or occulta, myelomeningocele, or myelocases. They are all what? Neurotube defect. That is all. This is the key. This is how you answer questions. He said, it does not matter. It's an example of neurotube defect. Then you go back, you ask yourself, what are the risk factor for neurotube defect? And what would you do to prevent it? That's all. So think about it. And I've given you options, and you can select which one you think will have prevented. Select that apply. Which of these will have prevented the problem? That's all. Once again, buzzword is the key and content mastering. Make the NCLEX very easy for you. Make it small as much as possible that you can manage. I ask you neurotube defect. Don't go and say so many things. Major problem is folate. Anything that is going to affect folate is a problem, right? If she was taking 400 milligram to 800 milligram of folate, this will have prevented the problem, right? If we have stopped the valproic acid, any anti-epileptic, right? Any anti-epileptic can cause the problem. There is some that have a very, very low risk of neurotube defect. They are very protective, and you can like lamotrigine, Keppra. There's some anti-epileptic that has less effect. They are not the best, but valproic acid is number one for causing is high risk for causing neurotube defect. So you could have changed it to another one that is much better, right? Then green leafy vegetables is a good source of folate. And then peanut has about 800 milligram of folate in it. Or you can eat some fortified grain that has folate. So when you answer questions like that, look if they're related. You can see, I see fortified grain and cereal of folate. Why don't you pick this? Then even if you don't know about peanuts, fine, you can let it go. But you know that green leafy vegetables is always good. That's what we tell you, because it has folate in it. And this, so at least A, C, and E, you can have choose it. But you don't have to choose everything if you don't know. That's it. If you don't know, but there's three answer choice there that at least you could have choose it. But all of them are right. Okay, so all of them are right. The NAS is currently preparing for potential intervention for the myelomeningocele. Now, I want to ask you if you know how to manage this problem, right? What is the management of this myelomeningocele? Which intervention the NAS should anticipate? Think about it. You have this sac-like bulge, the individual spine, like that, bulging like that, and with neural tube defect with the spinal cord like that. What do you think you need to do to this? First of all, you don't want to cause injury, right? So based on that, I've given you some clue about it. So what do you think things you can do? What would the next need to anticipate? Prepare for transfer to neonatal specialty unit. Cover the lumbar area with a non-adherent, sterile, and moist dressing. Place a drape over the newborn buttock. Maintain client in the prone kneeling position. Use non-latex medical supply or equipment. Prescription for antibiotic. This is the management. This question is highlighting management of spinal myelomeningocele, basically, or to prevent it from. We got to cover the area, but we should not use anything that is adhesive. If it's adhesive, it's not going to, it will cause problem. So non-sterile. You should not put any petroleum gel, anything, create heat, and then cause problem to the kid. So nothing like that, right? It has to be in a special unit. So transfer the kids to a special unit that take care of this dangerous problem, right? Even if you don't know, this is a test taking strategy. This is the abnormal neonatal problem. It has to be managed by specialized people. There's some questions like that you see on your NCLEX. Just try to use some test taking strategy and say, oh, this has to be a right answer. Of course, if you don't know, just leave it. But this is a bad problem. It should go to a specialist unit, right? Specialized unit. What does that mean? Number C, drape place a drape over the newborn buttock to prevent infection, so that if they have a bowel movement or they're urinating, it doesn't go. Then that's why you don't put anything on that lesion. So when you have a drape, it suck anything that is going to come out when you have the bowel movement, anything like that. So that's one. Then putting the kid in the prone kneeling position is better than supine. Supine is a bad position. These spinal cord injuries are also very, very sensitive to latex. So in order to prevent hypersensitivity, you should use non-latex gloves. And in order to prevent infection, you can have to give them antibiotics. So this is the management of this neurotube defect. If you don't know, I've given you everything. This is what they will ask you. There's nothing they're going to ask you. If they ask you about management of this is what you see, right? Avoid latex, prone position, prevent soiling of the sac by giving them a new drape, and cover the sac with the moist, not petroleum, moist gauze, non-adherent, and then send them to a specialist unit. Okay, we're talking about the same kid. I'm going to change the scenario. So I'm trying to confuse you. I'm trying to give you a bunch of information. These are like trying to teach you everything, at least a bunch of stuff you need to know for the newborn. And let's review the clinical data. Which finding will require follow-up? So I give you this. Now I'll give you a bunch of clinical data. At 12 o'clock, and let's perform full assessment and observe the following. The kid is irritable, inconsolable. Cry is like high pitch, trill, right? And then diaphoresis, sneezing and yawning. Are they all normal? Does it give you a clue of some diagnosis you should know? The kid is uncoordinated. Swallowing is bad. Head circumference is about 46 centimeters. Triangular shape posterior fontanelle. Diamond shape anterior fontanelle. Are they all normal? Think about it. There is a scalp edema that crosses the suture line. Are they normal? You should start writing normal as you take note about it, right? Tachycardic to 155. Is it tachycardia or normal? There is one artery and one vein in the umbilical cord. Is that acceptable? Is this something you should expect? There is a small polysystolic murmur you can hear, right? And the kid has a bluish discoloration of the hands and feet. Are these normal? Like I said, I created these tests to put everything in it so that you can, when you go to, even if you see standalone question, you will know. The respiratory rate is 45 breaths per minute. Is it normal? Is it regular? There is diaphragmatic breathing with apnea greater than 20 seconds. The chest circumference is about 30 centimeters. The kid has poor feeding. Abdomen is soft. He has umbilical hernia. He has single testicle you can palpate, and he has imperforated anus. Babinski was positive. He has Monroe reflex. He's strong grasp reflex, but the kid is hypotonia, and he has tremor. And you check the skin, he has thick, waxy skin coating. There's a fine, unpigmented hair. There's a parallel pinpointed purples on the face. He has a flat, bluish discoloration on the buttock. These are the things they put on your newborn cases, questions, especially standalone, and they have to ask you, which of these do you expect? I put it in the case for you. I hope you can figure out the hard ones. Now, this is it. So the next review this data, which finding will require follow-up? So which one? Does a flat bluish discoloration on the buttock require follow-up? Actually, think about it. Does a thick waxy skin coating require follow-up? A single testicle require follow-up? Umbilical hernia, fine unpigmented hair, respiratory rate of 45, that is irregular and diaphragmatic, and hypertonia. Guys, what do you think? Flat bluish discoloration on the buttock is normal. It does not require follow-up. This is like a patch. It's a birthmark. Once again, it's a birthmark. So number one is a birthmark. Thick waxy skin coating is also normal. This is the white venous, we call it, is normal. Don't worry about it. A single testicles is also normal. The kid is even less than 24-hour old. It's going to descend. It will take some time to descend. So if you fail at one testicle, usually two testicles, and sometimes one is undescended, but it will descend. At one day is not a problem, right? It will take some time. Umbilical hernia is a defect. It's normal in kids. That's where the umbilical cord come through. It's going to close. Sometimes it takes up to 2 years. It's normal. Don't worry about it. A fine unpigmented is normal. This is what we call lanugo. It's fine at the back of the kids. It warms them up. It's normal. Respiratory rate of the kids is 30 to 60. It's normal. They are usually irregular, normal, and they use their abdomen. That's why we call it diaphragmatic breath. This is all normal. A kid that is hypotonia, nah, it's not. That's not, you're not supposed to be hypotonia. It's condition, there's a bunch of conditions that will give you hypotonia. So hard question, but what is the purpose of it? To show you some of the normal things you see in a selected apply newborn, and then you fall for them. These are all normal. And let's review the clinical data. Which finding will require follow-up? The same thing, the same information we read, irritability, inconsolable, all those things we read. We went through all of them. I'm not going to go over them again, but which one will require follow-up? Now you have it. The kid head circumference was 46 centimeters. He has a diamond-shaped anterior fontanelle. He has one artery and a vein in the umbilical cord. The voice is shrill. That's the high pitch, right? There's a scalp hematoma that crosses suture line. There's apnea greater than 20 seconds and imperforated hernias. Which of this will require follow-up? Tell you that average head circumference is 30 to 33 centimeters. This is too big. So that's a problem. Anterior fontanelle is diamond in shape and is bigger than the posterior fontanelle, which is triangle, right? Triangular in shape. So this is a diamond. So this is good. There is usually one artery and one vein. No, you have two artery and one vein. So this is not normal. It's also not normal. High pitch cry is never normal, right? So this is not. There's a scalp hematoma that crosses suture line. So if this is your suture, that's the line between the scalp, the sutures in your head. There's a hematoma that crosses that. This is what we call caput succedaneum. It's also normal. It goes away in a week. So this is not normal. This is not abnormal. Apnea, you want to keep it to less than 15. At least 10 is okay. At most 10. Anything 20, kid who is having apnea more than 20 is not normal. So this is not normal. And of course, imperforated anus. That means there's no hole in the, they don't have outlet. So that's also a problem. But the scalp hematoma across suture line is called caput succedaneum, right? Shrill cries, high pitch cry, may be neurological problem. That's not good. And one artery and a vein in umbilicus is abnormal. You're supposed to have two artery and a one vein, right? A diamond shape anterior fontanelle is normal. And the posterior fontanelle is triangular shape. Head circumference of 46 is too much. It's between 30 to 33. So these are things you're supposed to know. So the kids has all of this problem that is not normal. That's all. They don't have any questions to ask you. The nurse notified the healthcare provider about the shrill cry, irritability, inconsolable with touch, hypertonia, tremor, yawning, and sneezing. Remember, the kid has all these symptoms. The nurse suspects the newborn is experiencing what? So remember when we saw that, if you look at here, inconsolable, irritable, shrill cry, diaphoresis, sneezing, and yawning. All these things, there's something wrong with the kid. What do you think? So this nurse was worried about it. Shrill cry, high pitch cry, irritability. You can't console the kid when you touch them. They have hypotonia, muscle is contracting really badly. They have tremor, they're yawning all the time, and they're sneezing. What do you think is going on with the kid? Remember what happened to the mommy? We don't know. Client report no prenatal experiment with no prenatal care, but experiment with alcohol and some straight drug during the pregnancy. I'm trying to lead you to something. That's why the kid is behaving like that. Is this hypoglycemia? Is it abstinence syndrome? Or is it unexpected newborn features? Or this is an ICP issue? It's not a newborn feature, as you can see. And this cannot be hypoglycemia because of the yawning and sneezing. Yeah, they can be irritable, but it will be hypotonia. They're not going to be hypertonia. Hypoglycemia will drop them down. The contraction will go down. So hypotonia. They may have temperature issues. This kid does not have temperature issue, but there's evidence of neurological overstimulation, signs of seizures. These are all absent, and the irritability and tremor are signs of seizure. So you know that this is the kid is withdrawing from something. This is not ICP. If it's ICP, I will tell you, I'll give you more symptoms relating to bradycardia, right? You're going to have bradycardia and what? Hypertension and bradycardia. So those are the key. Like I will tell you, the kid is cushioning, right? Hypertension and then bradycardia. But at the same time, I will tell you the kid is having feeding issue. I will lead you to that. It will be lethargic, right? There's no lethargy. There's no evidence of lethargy in that answer. But I give you neurological symptoms that is excitable, high pitch cry, irritability, inconsolable features, and tremor and yawning and seasoning. The kid is not lethargic, so it can be D. Like I said, I tried to trap you multiple times. So this is abstinence. The newborn is diagnosed with neonatal abstinence syndrome. Which intervention is indicated? If you know what NAS is, right, then you should be able to manage it. Don't worry. When they give you a name, scientists usually don't know how to define things. So they define it based on the content. It's neonatal, it's a kid. Abstinence, that means they're withdrawing from it. Syndrome, that means they will show a collection of symptoms that we need to prevent it, right? If you're withdrawing from something, and based on the symptoms I tell you, you can use it. The kid is irritable. When you touch them, they are unconsolable. They tremor and they're very hyper. What are you going to do? Slow them down, right? Key is slow the kid down. Therefore, what are you going to do? Avoid talking during feeding, notify social workers, provide small frequent meal, provide non-nutritive suckling between feeding, encourage maternal bonding, provide quiet environment, and a prescription for naloxone. What do you think? What do you think we should do? I can tell you, if you're feeding the kid, you should not be talking. It's stimulating. It's stimulating the patient. So low quiet environment as much as possible. So this is one of them. Social workers, of course, you got to get them involved. Small frequent meal is better than large meal so that the kid does not become hyper. It doesn't use too much energy and become excitable, right? And then suckling, pacifier will calm them down. Even though whatever has happened, you got to improve bonding between the mother and the kid. Quiet environment. As you can see, the answers is the same thing. I'll point something to you. How about G? Who want to pick G? And why G is correct or not correct. Once again, test taking strategy. The kid has NAS, is withdrawing. If he's withdrawing, why would you have to give you something that will take the medication away? The kid is withdrawing from something. Therefore, we should rather give them something to help them from withdrawing. We should not give them antidote related to the withdrawal. So watch for that. Naloxone is going to make the kid's symptoms worse, most likely opiate, right? It's going to block it. So what would you give this patient? What do you think we should give this patient who is withdrawing from probably opiate that we don't know? This kid needs some long-acting opiate, methadone, or you can give him low-dose morphine, but they need methadone, not naloxone. Naloxone is going to make the kid condition worse. Which of the following action will be, okay, I was trying to show you something. All of these answers is related to one thing. If the kid is having neonatal abstinence, syndrome, the answer is quiet environment, low stimulation. If you look at this, all of them is saying the same thing, like low stimulation as much as possible. So that's what you're giving the kid. So sometimes look at the answers, you can see that they're saying the same thing. They have to be right, or they are wrong. Which of the following action will be a priority for the NAS to take? So I'll give you a case again. The NAS obtained capillary blood glucose. The glucose is 39. So I'm taking you to a different scenario by the same patient, right? Now the NAS obtained at 1800, 6 p.m., you got a glucose. It was 39. The temperature is 98. Respiratory rate of 50. The kid has no tremor. He has no irritability. Once again, glucose of 39, no temperature, respiratory rate is normal, no tremor, and no irritability. What would you give this patient? IM of glucagon immediately, IV dextrose immediately, allow the mother to feed the newborn, and record this as normal glucose for the newborn. Am I trying to trap you? No. I just want to give you the content that you can master it. And this is, if this is your first time, this is Adapt NCLEX. Thank you for joining us. And symptoms, this kid is fine. He has no symptoms. Therefore, mother should feed the kid. At the same time, look, IM glucagon and IV dextrose is going to do the same thing. So this cannot answer the question. This is test taking strategy, right? A and B are saying the same. They're going to solve the hypoglycemia, but you give it to them when the patient has symptoms, so it's wrong, and this is not normal. The normal glucose 24 hours is 40 to 60. Now, the healthcare provider prescribed phototherapy. Which action the nurse should take during therapy? So what happened? This is it. Now at 7 p.m., okay, at 7 p.m., there was a yellow, the nurse found a yellow skin, scleral ectorate, clay-colored stool, and tea-colored urine. The bilirubin was 19. That means it's too high. Bilirubin is 19. It's too high. So what do you think this baby has? He has neonatal hyperbilirubinemia, right? Therefore, what would you do? Which action should the nurse take? Protect the eyes, cover the genitalia, apply lotions and ointment to prevent heat loss, encourage the mother to feed the newborn, stop all routine care, provide break from therapy every 4 hours, monitor for amount of wet diaper, continue IV fluid during therapy. Do you know what you're supposed to do with phototherapy? Bilirubin greater than 17 is abnormal. Bilirubin within 24 hours is abnormal. After 24 hours is physiologic, but this is pathologic. It's less than 24. The kid is 7 p.m. and we have this. Therefore, what do you do when you're doing phototherapy? Select or apply. Which of those he said the nurse should take. Which action should the nurse take? You got to protect the eyes, number one, right? Protect the genitalia, number two. No lotions, okay? No lotion is a trap. Lotion ointment will absorb it and it cause problem. So no, none of them. Don't use them. Mother should continue to feed the kid. He can take the kid off the radiant heat that is providing the phototherapy, and mother should still feed the kid. You should not stop all routine care. All routine care should continue, whether the kid is getting phototherapy, right? But you can provide breaks. Every 4 hours, you let the kid come out, enjoy themselves for a few, and then go back in. So you can do this. How about G? Monitor for the amount of wet diapers. Who think this is a good answer? Who think this is a good answer? The purpose of phototherapy is to get rid of the bilirubin. How does the kid get rid of the bilirubin? It should have bowel movement, and therefore you should monitor wet diapers. And you should continue to have IV fluid. This will wash everything out. Okay, so this is a case on phototherapy. I've given you everything. Now, which finding, when observed by the nurse, will require a report to the air care provider during phototherapy? Which of this will require follow-up during phototherapy? That means if the kid is undergoing phototherapy, which of this is bad? Bronze pigmentation, macular papular rash, dry mucous memory, and capillary refill greater than 3 seconds, yellow-green stool. This is to test your knowledge if you understand it. Give me your answer, and I will explain it to you. Prioritization 101. Bronze pigmentation is suspected when somebody is getting phototherapy. Maculopapular rash is also expected getting phototherapy. The major priority is dehydration. You make sure that's why you have to feed the kid. That's why mommy has to continue to feed the kid. That's why you give them IV fluid. You see dehydration, dry mucous memory here, and capillary refill greater than 3 seconds. I'm testing your mind. I'm trapping you. Oh, this is normal. Yellow-green stool is expected. This is your answer. C is the most important thing when you have to, if you see that they dry, yeah, the doctor needs to know. Of course, they have to have green stool, because if you don't see that yet, that means they're not responding to the therapy. But based on the 3-4 things I've given you, this require follow-up. The other ones don't require follow-up. Okay, this is a trap for you. Which finding will require follow-up? Once again, another information. After change of shift, the incoming nurse perform additional assessment. The kid has low set years, cleft palate, bulging anterior fontanelle when baby is crying, facial appearance consistent with fetal alcohol syndrome, deep plantar crest over the entire soles of the feet, white pearl-like epithelial cyst on the hard palate. There's a single transverse crest across the palm. And the fontanelle usually will bulge when you're crying, right? Your fontanelle will bulge when you're crying. So that is a normal. White pearl-like cyst on the hard palate. This we call it Epstein pearl. That is also normal. A deep palmar crest is normal. It shows that the kid is matured. By a single transverse crease across the palm is not normal. These two together will lead to a condition probably called Down syndrome. This is so you have to do a follow-up. This may be Down syndrome. You got to check for trisomy 13. So low set years and a single transverse crease across the palm. Like I said, this is like a lecture giving you everything, at least 80% of some of the things you need to know about newborn. After documenting the presence of cleft palate, now we know, right, which action the nurse should take to enhance oral intake for now. You know the kid has cleft palate. They're going to have problem swallowing, problem suckling. What would you do? How would you teach them? Guys, when they give you cleft palate, every time you study, you have to know how to intervene. And intervention is to teach the mother, they will need a specialized feeding bottle because of their lip, right? And you should still encourage the mother to breastfeed them. They will have problems sucking the breast. They won't have problems sucking a specialized bottle. But still, in order to improve bonding, you should still let the mommy feed them. You can also allow the mommy to pump, right? So that she knows she's bonding, pump and give the milk and put it in the specialized bottle and let the kid use it. Burping is a very good thing. They're going to swallow a lot of air. So you tell them burp a lot. So keep on burping the kid multiple times before and after meal. And the kid has to be fed in an upright position. So all of them are teaching you should employ when you're feeding the kid. Okay, with the cleft palate. I hope you understand that. The next assessment revealed features of fetal alcohol syndrome. Which finding is consistent with fetal alcohol syndrome? If you don't know, take a Google fetal alcohol syndrome. They have features. It will help you ingrain it in your eyes and your brain. When you see question, it will be easy for you. There are specific fetal alcohol syndrome features that you should know. I put all of them here. This is just to teach you. The face is flat. The mid face is flat. Because of that, they have a very short nose. Okay. There is no the epicondral fold in the inner portion of the eye is there, right there. You can distinguish. You saw everybody had phyllium. Is there's that ridge between your nose and your mouth. I mean, look at yourself in the mirror, and when you draw your nose like that, and then your upper lip, there is a ridge here like that. These people, they don't have it. It's flat. It's completely flat. That is what we call phaeton, and it's indistinct. So that means you cannot see it well. They have small, short palpebral fissure. The upper lip is very, very tiny. Their head is rather big, so it's small. Sorry, their head is micro, so they have microcephaly, and their nose is very small. So features of alcohol fetal syndrome is that this is part of it, this is part of it, this is part of it. So Google it, look at the picture, you will never forget it because the mommy used alcohol. Two more than with time. The nurse provide teaching at discharge regarding the sudden infant syndrome. Which statement by the mother indicate teaching is ineffective? Don't go and take the test and you don't know causes of sudden infant death syndrome and how to prevent it. It's common. It's common. The board will text you on common things, clinical aspect. You can go and take it and you don't know what causes it, what risk factors, and what teaching. So I give it to you. Make sure they're on a hard mattress so that they can roll and then they will be suffocated by that. So soft mattress is safe for my child. This said ineffective. That means they're saying something wrong. Mommy is saying something right, so ignore it. I will have bumpers in the crib to prevent injury. Bumpers rather cause injury, so this is ineffective. I will allow pacifier during napping. Yeah, it's okay to suck. Let the kid suck. Pacifier is fine. It does not cause problem. My child will have a wearable blanket. We call it sack. Okay, sleeping sack. You put them in it rather than putting blanket. If you give them a bunch of blankets, they may suffocate on themselves. So sleeping sack is very good for the kids. So this does not need intervention. Immunization has been proven so to be one of the risk factors. So the kid has to be up to date. I will ensure no loose feeding, no toy, no stuffed animal or pillow in the bed. So that is also good. Mommy should avoid that. So this does not need teaching. The only thing that I need is one As you can see, only one thing. She's saying something, only one. B, bumpers are wrong. Okay, but all the answers are right. And the last question. This is basically encompassing everything. The NAS provide additional teaching to the new mother at discharge on newborn care and expectation. Which statement by the mother indicate effective teaching? These are also little things you have to know. The cleft palate will be repaired in 12 months. We don't repair it right away. We allow the kid to grow, develop, and then before the age 2, it should be repaired. Then you can do the rest and think about it. I can expect the umbilical cord stump to turn black in 2 to 3 days. 2 to 3 days. Do you know about that? You should know about it. Umbilical cord will fall off by what? 1 to 2 weeks. You should know about this too. I will clean the cord stump with chlorhexidine. Check on this. I should expect my child weight to double by 6 months. Is it normal, right? A yellow exudate will appear on the circumcision site after 24 hours. I will clean it immediately to prevent infection. Is this something true that you're supposed to know? I will install a car seat in rear facing position at the back seat. I should expect weight loss of 15% of body weight 3 to 5 days. Which statement by the mother indicate effective teaching? So tell me. A is also effective. Like I said, 12 months minimum to repair it. The umbilical cord usually fall off by 1 to 2 weeks, right? It turned black, then it stayed there. By 7 days, it will fall off. You should not clean the stump with chlorhexidine. It's bad. You should keep it dry as much as possible. So this is a bad practice in the past. No chlorhexidine. Don't use it. The kid is going to double their weight in 6 months and triple it by year 1. A yellow exudate will appear, all right, at the site after 24 hours. But you should not wipe it. It's a weaning, is a part of the healing process. You should leave it. It will stay there for 2 to 3 days and it start healing. So don't wipe the yellow exudate. Mommy is going to do it. Tell them not to touch it. It's part of the healing process. So this is a bad teaching. This is ineffective teaching. Car seats should be rear facing. And then H, what do you guys think? The last one is wrong. 3 to 5 days, the kid is going to lose 5 to 10%. By 7 days, all the weight is back. They are birth weight. If you're losing more than 10, 15%, something is wrong because the kid probably is not getting nutrition well. And this is our Dr. NCLEX. Thank you for joining us.